The broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome to the May 2019 Pre-Hospital Care Research Forum, Educational Research Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of EMS professionals worldwide to build a body of evidence to examine pre-hospital emergency care. The PCRF partners with the National Association of EMS educators to promote research literacy and advance the science of EMS educational research. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. I'm Megan Corey, and I'm here with Dr. Bill Toon and with David Page. And the study we will be reviewing today is entitled Influence of Patient Race on Administration of Analgesia by Student Paramedics. And this was published in BMC Emergency Medicine in 2019. And we have both authors joining us today. So we want to welcome, and we'll bring them in just a few minutes here, Bill Lord, who's coming all the way on from Australia at 3 o'clock in the morning, and Sahaj Khalsa. Now, this review is paired with an article in EMS World called Research Alert, a review of original medical education research. We encourage listeners to check out this article at emsworld.com under the category of Education and Training. Now, it's not too late. There is a call for abstracts where you can use science to advance EMS. The deadline for educational abstract submissions is May 31st, 2019, and this would be for presentation at the EMS Educator Symposium in Fort Worth, Texas, and that's happening in July, beginning of August. And the deadline for clinical and systems abstract submissions is June 30th, 2019. This would be for presentation at the International Scientific EMS Symposium, the EMS World Expo, October 14th through 18th in New Orleans this year. Remember, there are cash prizes for the best research and an opportunity to go overseas and present at an international conference. Visit prehospitalcare.org to learn more and to submit your abstracts. That's at prehospitalcare.org. If you have any questions, you can email us at pcrf@mednet.ucla.edu. Thank you all for joining us. So we're going to begin, and we want to remind listeners that you can use the chat feature on your screen to type in questions and comments, and we will bring those into the conversation as we go. So a little background, healthcare disparities have been documented in the research literature for decades, and we've talked about this quite a bit on this podcast. Studies from acute care and other healthcare settings have revealed disparate treatment and prevention strategies, particularly for Black and Latino patients. And several pre-hospital care studies have revealed disparities in the provisions of care and identification of acute conditions that require evidence-based treatments like acute stroke and myocardial infarction. Delays in treatment and higher mortality are also noted in the literature. So this study aimed to examine factors associated with the administration of analgesia during paramedic field internships, as documented by paramedic interns. So let's begin this discussion by having our authors join us now. Like I said, we have Bill Lord, who's joining us from Australia, and we have Sahaj Khalsa. Bill, why don't we begin with you?
Thanks, Megan.
Why don't you introduce yourself, tell us what your affiliation is and where you're from and how you came to doing this research.
Yeah, thank you, and thanks for the invitation to be part of this podcast. I'm currently the discipline lead for paramedicine at the University of the Sunshine Coast. This is one of the 16 universities in Australia that prepare graduates for practice at a bachelor level. I've been working in the university sector as a paramedic educator for around 20 years. I came to this research through an opportunity to attend the Fisdap research workshop in Minneapolis a few years ago when we were generating some ideas to study, and this was one of the ones that came out of that workshop.
Yeah, that's great. So that's a Fisdap Research Summit. For those of you maybe who haven't heard of this, we've actually talked about this a couple of times. I think we've had maybe one other presentation here based upon the Research Summit in recent times, I'm sure several in the past. So it's a great opportunity to take basically a international from internships records from paramedic programs. And we'll talk about which kind of data are included in this, because it's not just everyone who enters data into this data set. There actually has to be an approval and a consent and a flag for good data. So we can bring that in. Sahaj, can you introduce yourself and describe how you came to this?
Sure. So I'm the paramedic and EMT program director at the Santa Fe Community College in New Mexico. I've been involved in EMS in one way or another since I graduated from high school in 1993. And I've been interested in research and in disparities for a while. And this project actually it was something I was interested in, but then Bill had begun the process and I joined him after he had already started the process at the Fisdap Research Forum a year before I got involved in it. So I've been interested in this type of research for a while, and that's how I came to be involved in this particular project.
And Sahaj, can you comment briefly on the work group that is happening, or the committee, the Cultural Competency Committee at the National Association of EMS Educators?
Sure. So that's actually another role that I have, is I'm on the board of the National Association of EMS Educators and currently serving as the chair of the Cultural Competence Committee. And we are working on a position paper in that organization to try and discuss how educators can have an influence on exactly this type of thing, to change the narrative, to change the reality that we see that our minority patients are receiving consistently worse care. And we believe at the Cultural Competence Committee that as educators and as effectively the gatekeepers to the profession, that we have a responsibility to examine our role in all of this and these findings, these unfortunate findings, and see what we can do to move the needle at the educator level.
That's great. So we can bring in some of the background too as we're going through your research, but certainly because you've had some experience in this area, and then now we have an international group of researchers looking at this. This is not just a national problem; it's an international issue where we see disparate patient care based upon different elements depending upon where you are in different countries. But healthcare, the World Health Organization has several initiatives out to address the inequities in healthcare and the social determinants of health outcomes that we've seen. It's more recent that we've seen this kind of pour over into pre-hospital care. Although it was 2015, I believe, here that we talked with Dr. Govindarajan from Stanford on a study about the disparities in identification of stroke in the field, and that was based on race and gender. So there have been many different areas where we've seen this, and I'm glad you said it the way you did, where it really is a call to more closely examine the factors that are related here. So let's jump in a little bit here. And actually, let me ask you, were there anything in your background research that stands out that you would recommend for educators to read as a maybe a primer on this research on disparities? Any seminal studies or background for EMS educators to become sort of more informed?
I couldn't identify a seminal article, to be honest, that has a pre-hospital focus, and one of the reasons is the limited number of projects that have addressed this issue. There's, as you say, many other research findings or outcomes that have been published around disparities. I came to this originally through my doctoral studies, which was all about looking at paramedic management of pain, where I identified disparities in analgesic administration by gender and age, as well as type of injury. I've repeated that in a few other contexts, and we've repeatedly found that females are less likely to receive analgesia than males. So there are a number of papers out there, but it's a good question actually. What can we recommend people to go and have a look at to summarise what we know about disparities in paramedic-led healthcare?
And maybe it isn't just paramedic-led too. I mean, because we see, you know, acute care, differences in acute care, there can be some extrapolation, you know, into pre-hospital care. And Sahaj, you were going to say something?
Well, I think I would echo, you know, if we're looking for a singular study, I don't know that I've seen one. What I would say is that if you merely scratch the surface, you will find a plethora of research articles that talk about disparities in not only care, but also in education that I think it's incumbent on us to understand and work to address. And our hope is that we can, it might be a bit lofty to say that our position paper from the Cultural Competence Committee will become the seminal article on this type of thing, but we're hoping that it'll certainly provide a introduction to best practices for educators and tools for educators to try and both introduce these concepts to their students and also learn what they may be doing to reinforce these, inadvertently doing, to reinforce the concepts that we find pretty much everywhere in education and in healthcare relating to disparities.
And to extrapolate even further, last year I know, and I think Sahaj, you were on the webinar for this one, we talked to Cynthia Ferranda, who is a nurse educator and researcher in Florida, who published her dissertation research on the use of simulation and the use of cultural humility practices, which is, I think, a term that's catching on and is much better, has more depth. Cultural competency, as we can talk about later, kind of suggests that you can become competent, and therefore now you're done, go off and
exactly.
You know, and whereas cultural humility is an ongoing reflective practices, you know, always a self-check on, am I, and not just associated with things like race and gender, but also just culture, meaning differences between individuals for a variety of reasons. And it has to do with communication and your understanding and your ability to see something from another viewpoint, which I think is a very interesting concept. And unfortunately, in that one, we talked about the lack of use of these principles in simulation, and a lot of it being, how do we do this without stereotyping, without, you know, imparting our opinions about populations of people and that kind of thing.
It's interesting. We've chosen to use the term cultural safety across all of the registered health professions in Australia, and that again reflects what you're saying about it not being a achievement of an endpoint in terms of a competency, but rather a continuous process of cross-checking to ensure that when we're caring for people from particularly minority or disadvantaged groups, that we're doing cross-checks to ensure that we maintain safety.
Yeah. So with your background then, why don't you walk us through like how you started when you met at the Fisdap Research Summit and you were talking about, okay, this is what I'm really interested in. I want to see if paramedic students, if we see this among the student population, if we're seeing this association of or differences between administration of analgesia among various aspects of the population. So how did you come to deciding how to look at that, and tell us your methods?
Well, I guess the Fisdap Summit is a great opportunity to brainstorm, to identify gaps in the knowledge base, and this was one of the factors that came out of it. It wasn't fully developed during that forum, but I left with that in mind, given the previous work I've done in pain management that's shown disparities across other aspects of pain management, and I came away from that thinking this is really interesting. And what fascinated me, of course, was the fact that you do capture information about race when you're generating patient care records, which is, I have to say, unfortunately not done by EMS in Australia. So we don't typically record, even though we've got a very culturally diverse nation. We don't have the capacity to examine disparities in care by paramedics in Australia. So I thought this is a wonderful opportunity to study this, and I worked with colleagues at Fisdap to run a couple of data pools to do some initial analysis of what was possible to see whether we had actually the type of data that we'd need to run a study of this nature, and it went from there.
And Sahaj, did you have? I mean, how did you decide on your methods?
Well, I should be very clear that Bill Lord was the primary driver of this, including the choice of methods given his background and experience. My involvement was in an interest in pushing this forward. So when he came, he returned to the Fisdap Research Summit for year 2, and this project had not quite neared completion. And we had talked about it, and I had expressed interest, and we then collaborated on finishing out the project. But to speak to the specifics of the methods, I would defer to Dr. Lord.
So we see that data were extracted from the Fisdap database, and that's one of the things that happens when we're on the research summit, when we're working on this, is we have to understand the database. So if you're out there and you're thinking, okay, I'd like to look at some of this myself in my own data. So we have to understand the limitations of a database, but also first search for, okay, what is it that could help me, determine this? So this is a huge database, and so we're looking for analgesia, and we're looking for a determination of a variety of factors that might affect the administration of analgesia. And we know that both of those things are going to come up with, a number of different areas. You're going to have missing data, you're going to have different forms of analgesia, you're going to have different means of giving analgesia, you're going to have different indications for it. So how do you sort all of that out, and how did you settle on trauma? Because I noticed you settled on trauma, not chest pain or and myocardial infarction or other things. You settled on trauma.
That's right. Trauma was selected as essentially a surrogate for the presence of pain. I appreciate that that's not perfect. There is evidence of that variable being used in other studies where, as was the case here, we've got quite a lot of missing data in pain severity scoring, for example. It's unfortunate that pain scoring's often not done routinely, and so you've then got to go and look for another variable that may indicate the presence of pain, and so that's why we chose trauma. We also had to exclude head injury because I'm aware that for reasons that are not particularly clear to me, head injuries are contraindication for analgesia in some parts of US practice guidelines.
Yeah, and I think you make a really important point there. So if you're out there and you think, I want to do some research, and then you look at a database and you say, well, they don't really measure what I want them to, the next step is to say, well, what's close? What's the closest thing where I can possibly capture? And, this is especially true of when you're talking about disparities, because at some point you have to say, hey, if we're noticing disparities, despite the way we're measuring it, it's still important. It's still why are we picking this up? So that's something that we'll talk about when we get there. But so you chose trauma, you had you excluded head injury, and then you also looked at different types. So you made sure that you measured different types of trauma because there are confounding variables, and we've talked about this on this podcast as well, that you have to look at what are other factors that might influence the administration of analgesia besides the things that we're looking at, which in this case, looking at patient race. What are some other things that are independent of patient race that might affect that? And so those are things that you wanted to look at, some of which you couldn't capture from the data, and that's listed in the limitations. It's something we can describe in the limitations. So let's talk about. I have table 1 up. It's kind of a busy table. We're going to leave it here for a little bit so we can talk about it, because it does describe what you were actually able to draw out of this this data set. So describe to us. You had a total number of patients who received analgesia, is what you started with, right? Ages greater than 15 and less than or equal to 100, and then you had age groups that you formed later. Alert and oriented had to be yes, and primary or secondary impression had to be trauma. So those were the records that you started with. And we see 59,000 here, but I believe you started out with a data set of almost 300,000 unique cases. And then after you applied your inclusion criteria, you came to these 59,000 available for analysis. And race, incidentally too, you mentioned race, and we'll talk about this as we get moving, but race is recorded in 41,071 of these cases, and 31% of cases missing race data. And then you had patient severity recorded in 26,000, a little more than that.
Yep, that's correct. So we did start with a very large data set, and we, after applying inclusion-exclusion criteria, which also required the preceptor to have noted that it was a good record. I can't remember the term that's used in the Fisdap database, but it essentially requires the supervisor or preceptor to verify the accuracy of the student record.
And it also requires the program director, I think, to flag this as good data, I believe. Sahaj, you can correct me if I'm wrong on that, but I think you have to say, okay, I've audited and this is good data.
Yeah, so the preceptor has to sign off on it, and then depending on the program, it's somebody at the programmatic level, whether that be a clinical coordinator, program director, or some other instructor, who is auditing the data that the student has entered and saying, yes, this is good data. And I believe the term in Fisdap is that it's flagged for good data, which tells us that they've gone through that process to validate what the student has entered.
And the student has consented to. So we do want to encourage instructors and students out there to, when you do log in first to Fisdap and you start your account, you'll get an explanation of how your de-identified data entry may be used people to consent to this, and encourage educators to support that effort. And if you have any questions, of course, to ask at Fisdap support. So I think it's a really important thing. It contributes to this body of knowledge. So can you help us then understand this, what happens now? What are we looking at in this table when we have the number of patients that receive analgesia versus no analgesia, and what we're seeing? What are some highlights in this table?
Yeah, this is essentially demographic descriptive data describing the population. It shows that firstly, the first line looks at how many patients received analgesia, which in itself is interesting, if not disturbing. 14% of patients who experienced an injury or who were recorded to have suffered an injury received analgesia. And if you look at the records that did have a pain score available, when we looked at the median score, it was 7 out of 10. So that stood out for me initially, because when you look at other international data, and I've just recently completed a study in the UK with other colleagues there, and also compare it with practice in Australia, the rate of analgesic administration is actually very low.
Yeah.
Yeah, and can I add to that?
Go for it.
So I shared, Bill's surprise at that finding, and I also think it's important to note, because a lot of people have said, well, there's all sorts of criteria around administering narcotics and a lot of paperwork and on, and that may lead to the low rate of any analgesia administration. But the way this study was conducted, it didn't just include narcotics as analgesia. It included other non-controlled substances as well, such as Tylenol and ibuprofen, which could be administered for pain. And even including those non-narcotics, we still only arrived at just over 14% of patients, received any treatment for their pain, any analgesic treatment for their pain at all.
And what about patterns between mild, moderate, and severe pain? Were you able to break out any of that? I know it's not in here, between whether they received opiates or non-opiates within each of those categories.
No, that wasn't part of the analysis. We chose just simply to look at whether analgesia had been provided or not. So that's a no to that question. We, certainly in other studies, we've found that which is not surprising, the higher the pain severity score, the more likely people are to receive an opioid rather than a non-steroidal anti-inflammatory, for example.
We have a question about the methods too. Did the missing data bother you at all? How do you manage a large percentage of missing data in your key variables, including missing race and missing pain? And do you feel that these missing data are missing at random and don't bias the results if they've been excluded? And then a question about the categorizing pain scores and age rather than using them as continuous variables. Is there any reason you handled it that way? So let's talk about the missing data first.
Yeah, sure. The missing data in any study of this nature, retrospective review of patient care records, is always going to be an issue. You can see under the results section that we address the missing data through the analysis that was used that resulted in, at least for the adjusted odds ratios that are presented in Table 2, 17,729 unique cases. So there is a description in that section as to how we address the missing data.
And one of the ways that, and we've talked about this a little bit in terms of methodology on this webinar, which is one of the ways we look at it is to compare your population that you have been able to look at, without the missing data, and maybe percentages of patients within each category of race, and look at that in the general population or in the general population of even including, other research that's been done out of the Fisdap Research Summit, or, just in general EMS population. And that's one of the ways, you have a comparable group to actually say, yes, this looks actually pretty reflective. However, this is a specific population in terms of the type of injury, right? So we've already kind of gone down to trauma patients who have pain. So it would be hard to find. Not sure what comparable group you would look to see whether you could compare and say this was, this is probably a representative group, and we don't think there's an underrepresentation of one versus another. So walk us through the age categories. How did you determine your age categories, and what are we seeing here? And then we'll get into the primary outcome in just a second. I want to walk through some of these categories that you have. You have cause of injury and you have age, and we just went through pain score category. Yeah,
sure. Age categories were, rather than treat age as a continuous variable, we decided in consultation with my statistician that it'd be better to develop categories, and this is again based on other research. It's not just research I've done. So the categories are consistent with other research methods, and we were then able to look at some chi-squared testing to see whether there's any differences between those categories. There's not a lot of that I can comment on in terms of just looking at the descriptive results in this first table. The other thing you asked was about cause of injury. Now, there's many causes of injury listed in the Fisdap system that students can choose to categorise the type of injury, and we had to make a pragmatic decision to group injuries by categories that we'd determined. So that was essentially just expert opinion, but you can actually see within the paper how we arrived at those categories.
Okay, so can you describe then what we're seeing? In table 1, you have descriptive statistics, and then we see the p-values over on the far right. So what are we looking at in terms of differences within these categories?
Well, the sex, for example, is not statistically different between males and females, and all of the others indicate that there are statistical differences between the categories, each of the in terms of race, pain score, age, and cause of injury. But just looking at the p-value really doesn't tell us much. We need to look at the results of the adjusted odds ratios that are shown in table 2 to try and make more sense of that.
So let's look at table 2 then. I'm putting table 2 up here on the screen for those of you who can see it. This is the logistic regression analysis of the odds of a patient receiving any analgesia. So in the descriptive table, you could see the raw numbers and the percentages, and then a p-value over on the right. Here, we've got an adjusted odds ratio. So walk us through this table.
Sure. So this is the table that really is the basis of the whole paper. It's the this is where we've adjusted for variables that may have influenced the outcome of interest, which was receiving any analgesic. And the way we did that is quite detailed, and it's described in the paper for people who have an interest in the method. This is an open access article, so it's freely accessible to anyone. So we controlled for variables that we identified have an effect on that outcome of interest. In race, Caucasian is the reference, that's why it's got a number 1 next to it. And so we're comparing the other races with Caucasian to arrive at a number that indicates odds of receiving analgesia. So if you look at African American, you'll see the odds ratio is 0.60, and the confidence interval, which is in the brackets beside it, ranges from 0.53 to 0.69. So that means that in comparison with a Caucasian patient, an African American patient is 40% less likely to receive analgesia. And,
so that's
and
what we're seeing.
Yeah, and that's significant. You can see the odds ratio, the confidence interval doesn't cross 1, but it's also indicated by the asterisks that that's significant as well. And what's missing from that slide is that the 3 asterisks indicate a p-value of less than 0.001, so highly significant. The other races are not significant with the exception of Hispanic. So again, if the student has indicated that the patient is Hispanic, those folks have an odds ratio of 0.81. In other words, 19% less likely to receive analgesia than a Caucasian patient.
And where do we see no statistical difference in other populations, in Asian, Native American, and other?
That's correct.
Okay. So then now we've got to talk about what other actually let's go to injury cause for a second, because one of the things that I wanted to ask you about with injury cause was one of the first things we think about is what are some of the factors that influence administration of analgesia in general, and not just injury cause, but you talked about body area before as well. In their paper, at least you mentioned body area, and I always think, okay, what about body area? Because a lot of protocols will have pain management for severe extremity trauma only, or for burns, a type of injury. So, the likelihood of seeing analgesia administration in those settings might be higher. Whereas in here, we're seeing injury cause. We're seeing fall and violence and firearm and stabbing, environmental transport. I'm not sure what transport means, but and then toxicological and trauma other. Those are the categories we see here. What does transport mean?
It means that an injury has been sustained either in a motor vehicle collision, motorcycle, pedestrian, fallen off a horse, bicycle, so any injury sustained by those means. And I agree that when you've got clinical practice guidelines that restrict analgesic administration by cause of injury, that makes the analysis complicated. And I guess that provides an opportunity to reflect on whether clinical practice guidelines in people's area of practice are actually evidence-based, because on this side of the planet there are very, very, very few contraindications to analgesia, including opioids. I mean, we just don't limit the use of opioids to extremity injuries. It's or even level of consciousness. There's no reason why a patient with an altered level of consciousness who has a painful injury shouldn't receive analgesia.
Right, and we have a few people that are actually joining us in the audience, and we're going to unmute Jamie Kennel. I believe Jamie Kennel's been on here before for work, similar work that's been done, and I don't know if we have him unmuted. Do we have Jamie unmuted? Maybe not yet.
Yes, I just unmuted him. Jamie,
there we go.
There we are.
Great.
Welcome.
Good morning. Thank you. Thank you. And thank you to the authors for this. I think it's a fascinating study. And as was mentioned by Megan, I do very similar work in the States, and have looked at very similar issues around racial treatment disparities in EMS. So I'm excited to see this paper come out and have it be part of the discussion. I was curious, one of the challenges that I have, and I should say my training is in sociology, and I'm also a paramedic, so I approach this from a slightly different perspective than a clinical perspective, and we can argue in some ways that's good, some ways that's not. One of the things that I struggle with, and some of the sociology scholars that look at treatment disparities, is the tightly confounding relationship between socioeconomic status and race.
Yes.
And I noticed in here that you've not had controls for socioeconomic status. So I'm wondering, how do we interpret the results to know if race is really driving this, or is there a socioeconomic status difference that's driving these disparities?
Yeah, you're right. There was no data or insufficient data to, be able to identify socio-economic status. But even so, I mean, I've looked at this in previous studies, and that's actually difficult to measure. I mean, do you measure
Absolutely.
it based on the patient's location, because they may be in a completely different location to their home when they sustain the injury? So it's actually, I think, quite a complex variable to include in the analysis, indeed, if we could have. And I acknowledge that may have influenced the results. In many ways, I see this, because of the limitations associated with this research that are described in the paper, I see this as an opportunity to generate discussion and perhaps inform further study.
Yeah, I completely agree. Yeah, go ahead.
Dr. Bill Toon would like to join in here. Bill, other Bill, are you here?
Yes, I'm here. So it would be interesting to know how much the students, and I may have missed that you touched on this, were influenced by the people who were precepting them more so than their feelings, because I know that this is a look at a database with documentation of this. So I just find that, that would be more of a deep dive beyond using the databases to get into the minds of the providers and see, who's really influencing this decision, or how are they being influenced in their decision.
Yeah, I'd like to ask Sahaj to address that, because you're more familiar with the preceptor process in the US than I am.
Yeah, I think it's a great question, right? And it's a question that I think we need to try and figure out how to answer, because we're looking at students because that's what the Fisdap database holds. It is possible that the student who is operating under the supervision of a preceptor wanted to administer analgesia, but was prevented from doing so by their preceptor. I'm hoping that this type of a paper, which this research will, as Australian Bill just said, will start a conversation on digging deeper into the data to figure out exactly what's going on here. And as Jamie just said, there's so many different factors that are involved that it's incumbent on us to not just accept the results as they are, but to dig deeper to find out what exactly is driving these results. And hopefully with more and more services and states going to electronic charting, and I think probably everybody is there now, we'll have a better opportunity to do that type of research going forward. Certainly a better opportunity than we have had in the past.
And if I can make one comment here, I think, Bill Toon, maybe this is something that you're getting at, but also related to this, there's an analogous situation known in medical schools of the hidden curriculum, which is that students enter medical school process with possibly a lower level of evidence of treatment disparities, but as they work their way through medical school and specifically spend time with attendings during the final phases of their medical school, their preceptors may, as they're modeling behavior, have a large influence on the eventual disparity of the student's care as well. So I suspect there may be some of that influence happening here in paramedic school also.
Sure.
Great point.
And if I can respond there, this brings me to, from the educator perspective, to figure out what role do we have as educators to address that, I think you called it the hidden curriculum, right? And what role do we as educators have to root that out, especially as it relates to this type of thing? I mean, there's research that shows that there are unfounded biases that exist in physicians that perpetuate throughout their medical school training. And I think we'd be remiss if we assumed that such similar things didn't exist in our paramedic training programs. And so I think we should be examining all of this stuff, both as educators and as providers, to figure out where we can push to make a difference.
I agree. Thank you for letting me comment.
Yes, thank you for joining us. We're going to have someone else come in here too in just a second. One of the things I would like to say, first of all, congratulations to the researchers always, and for bringing this to an online open access format so we can all actually join in on this discussion this early in the process, right after publication. So we'd like to see more of that out there. But the other thing I think is really interesting about this database is the determination of race is student generated, right? I mean, this is the practitioner who is determining this. And we don't know how. Is this by a judgment of how the patient looks? Is it by them asking the patient? Where is that coming from? So that may account for some of the missing data as well. There may be something where a student doesn't know exactly how to do this, or whether it's accurate or appropriate, or whether a person can be in a category, whether multiracial individual. So that actually alone, I think, makes the database a little powerful, because you're automatically getting data that's coming from the judgment of the student or the preceptor, not from a Census Bureau. And that kind of gets at what you're talking about, Sahaj, I think.
Right. Well, I think that you're exactly right that we don't know exactly how patient race was generated in the chart. We know it was student entered, but beyond that, we don't know if the student asked, if they, just made a judgment. We're not sure. But the bottom line is, unless they asked, that this is a student's perception of their patient's race. And fundamentally, that's what matters, right? Is what the student perceives their patient to be. That seems to have an influence, that has an influence on how that patient is then treated.
And you raise the issue in your paper too, that we don't know what the race is of the student or the preceptor as well, which actually I think that would be interesting to look at too, because and this is not based on really anything, but it may be that we have a medical culture, this may not be a identification of race issue, meaning that it may not have to start with, well, I'm a different race than this person, and therefore it may be something that we have propagated in sort of the world of medicine or the world of EMS rather than and our impression of patients based on race. So,
sure.
We have Brooke Burton on, who is also someone who has been at the Research Summit, who's done some research in this area as well. Welcome, Brooke.
Hi, Megan, and congratulations on your research. It's very interesting stuff that I've been looking at for a couple of years now. What I found was amazing is how close the numbers that you found were to numbers that we found in a national database last year. So looking at Black patients compared to white patients, we also found a 40% less likelihood to receive analgesia and 21% for Hispanic patients. So very similar to what you found. The main difference that I noticed is your 14% overall analgesia rate. When we looked at trauma patients with a pain score of 7 or higher and marked with an injury, we actually found nationally in our study that the rate of administration for analgesia was only 9%. So even more shocking than that 14. And it floors me that that it's so low. And I also think students are usually on their best behavior, trying to do the best for their patients when they're brand new. So, to see that decrease as people, as in a non-student database is an interesting point to bring up too, I think.
And Brooke, this was out of a patient database, correct? This was out of ESO, was this?
Yeah, it was the ESO database for 2017 data. It was about 5 million records across the country.
Okay, so this was also patient. So this was patient treatment, on that end of the spectrum, which is what you actually mentioned in your article as well, Sahaj and Bill. You guys mentioned that this is from a student database. This isn't from a treatment database. Well, now we're hearing from someone who has looked at a large data set from a treatment database in the pre-hospital setting and found similar results.
Sure. Yeah, I think it's important to note that as we're hearing from other researchers, these results are quite far from being outliers. They actually fall within the somewhat limited, but still the body of research that is out there. And, regarding the difference between 9% to 14%, so some people have thought, well, maybe didn't record when they administered analgesia. And actually, I would argue that students are incentivized to record because they have to meet certain numbers as they attempt to complete their paramedic education. And that is perhaps why we see the difference from the 9% that was found in provider data and the 14% that we found. And I think it raises the question of what is the bar to administration of narcotics? And I would argue that we should now be looking at, what burden is put on providers when they administer analgesia to their patients. Is it difficult to get to? Is it difficult to then document? Is it difficult, or does it predispose you towards getting your charts reviewed, and maybe there are systemic non-incentives towards administering what is appropriate care to our patients, and we should be looking at that as well.
Yeah, and I think this is Brooke again. I think it's kind of all of the above from, talking to a lot of different providers. Also, I heard, oh, I'm only 5 minutes away from the hospital excuse. So I would love to see a study that shows patients who don't get analgesia in the field, how long it takes at the hospital, because I very frequently see that 5 minutes at the hospital turn into 45 minutes or once the patient's at the hospital.
So Brooke, I'd love to talk to you about that, because I've heard the exact same thing and my response was identical. So it's something I'd love to figure out how to measure.
Well, one of the other things, we talk about diversion too, and we talk about wall time, and people always talk about how long they wait, in the hallways for care. And that's why the whole idea of transport time, I just don't even like that as a variable personally. Someone else had something. Was that Jamie?
No, this is Bill. So it's, there's a number of very interesting things that build into this. It would be interesting, as I continue to listen to this, some things that would be very interesting if we had the ability or can grow into the ability to do this is over time. It would be wonderful because of national data banks that we can take the student record and it gets matched with the pre-hospital care record, and it gets matched with the hospital outcome data, because think how powerful that would be in the sense of connecting all of this stuff, this information across the, continuum of care, from the student perspective to what ended up in the EMS chart, actually then what ended up being the outcome. But how many people do we know what their biases exist before they even get into the profession or the practice, or unconscious biases that they may have? And I'm thinking there must be a tool out there that's used to evaluate that now. So even a more powerful thing possibly would be to do is to know where students' biases are at the beginning of their education program, and do they change by the end, and if that has any influence on how they provide treatment to patients.
That's an important point. I think, though, too, even if you measure biases, how I think the second part of that is the most important is, how is it influencing your care? So is this, if you enter with a knowledge of, I have these biases, are you, and this is the whole idea of cultural humility, I think, is this constant self-reflection and introduction to a variety of different, I don't know, for lack of a better word, cultures. The only reason why I say lack of a better word is when that seems to drum up issues of, different ethnicities and different races, and culture has such a deeper meaning. But does it actually influence their care?
Yeah, and just, that I think that I heard some of the other speakers touch on this. How do we, I find myself even now challenged when I fill out my electronic record and it asks for those questions dealing with ethnicity. What is the best way to get an answer to that? Is it what I believe it is from my observations, or is it best to ask the patient how they would identify themselves, and what is the most common practice?
That is such a great question, and I don't know if any of you want to answer that, but I think it definitely matters in this. I mean, if it matters in how we evaluate this data. If you're asking someone to self-determine versus actually, making that determination based upon whatever factors, the way a person speaks or how they look or whatever, you can interpret that a little bit differently. And if David had to leave, but if David Page was here, David Page, who is also Mexican, who looks Caucasian, he might say, well, it does matter, because how I will determine and how I will identify might be different as how somebody will identify me.
I think asking the patient is a great example of what I call a cognitive forcing strategy, because it provides people with the opportunity to reflect on whether their assessment of race or ethnicity is influencing their decision making, but it also gives you an opportunity to explain to the patient that you want to capture this information to ensure that we don't see disparities in care.
Yeah, it's interesting.
It's a challenge, and I just wonder what degree of inconsistency exists.
I think.
Yeah.
Can I jump in here?
Yeah, sure. Go ahead, Sahaj.
Yeah, so I think there's a number of things that I think we should be doing. One is I think we should try to figure out a way to destigmatize bias, and that sounds like a strange phrase, but everybody has biases, right? There's tests online that you can measure your own, or have your students do, to measure their own unconscious biases. But then we have to be able to have an open conversation about the difference between having a bias and acting on a bias. And
thank you.
They're very different things, right? So, and acknowledging that to begin with, and that is a starting point that we can then move forward from. And the other thing I think we need to do is remove this from a discussion that's based on an individual level, right? We're not fixing this on a one-to-one basis alone. Of course, we need to intervene there, but we need to look around and realize that this is a systemic issue. And there's some evidence out there that shows that even when you have minority providers caring for a minority patient, and you have patient-provider concordance, racial concordance, you still see disparities in care for that patient. They're just not as large as the disparities when they're cared for by a provider of a different race. So it's critical that if we really want to solve it, that we don't focus solely on the individual, and instead that we focus primarily, and I would argue, on the systems that lead to these type of disparities. Because I believe that the people who get into this line of work, on the whole, mean well, their heart's in the right place, they're not out to treat people differently, but we all exist in systems where biases are baked in.
I think that's a great comment. We're approaching the top of the hour, but we'd like to give everyone a chance to contribute. So, Bill Lord, do you have any thoughts as we wrap this up, this discussion? I don't know if he's still awake.
I'll just unmute my microphone. Again, thank you for the opportunity to participate. This is a really important issue, and it's also a very complex one to solve. And we've made some recommendations in the discussion section about how to do this. And I think, as we've said, some of this is operating with people are operating at a subconscious level of bias. How do we address that? I'm using some strategies in my teaching in simulation to force students to address biases that might be affecting their decision making. It's based on other work that's being done in other areas of health. I have no evidence whatsoever that it's actually working, but I think we've got to work on ways to help students bring whatever's affecting their decision making to a level of consciousness to enable them to determine whether that's affecting the quality of their care.
That's great. Bill Toon, do you have any final thoughts?
I have lots of thoughts, but I'll limit them at this time here. And I want to thank the authors, not only for the paper that is done, but for taking the time to come on here and dive into some of the details of it to give us give us depth and breadth to it. It really helps us understand a little bit more of what's going on, but it is a complex topic that certainly needs more work. There's always more work to be done. There's probably more work than we can do, but it helps us move us along as a profession. So thank you very much.
Yes, and thank you to those who came off and joined us. Jamie and Brooke, thank you so much for unmuting and contributing to this important discussion. There's so much more to talk about. We didn't get into a discussion of language differences and other things that we'd like to get to. Let's continue this discussion in another forum. Don't forget that the National Association of EMS Educators Symposium is coming up, and a lot of great work that's being done by the Cultural Competency Committee. Congratulations to the authors and congratulations to that committee for working on a position paper to help guide educators in how to discuss these issues, have these discussions, and bring to the forefront these issues in EMS education. So thank you all for joining us next month. Don't forget, we've got the Education Research Podcast again on Friday, and actually we've got that switched. I constantly do this. I'm sorry I switched these things. This is actually the clinical podcast is June 10th, which is a Monday, and Friday, June 28th is the Education Research Podcast. Both are at 10 a.m. Pacific, noon Central Time. And if you want to present an upcoming article, please email David Page at dpage@emsed.net. And thank you for joining us.